This is Dr. Ben Weitz with the Rational Wellness Podcast, bringing you the cutting edge information on health and nutrition from the latest scientific research and by interviewing the top experts in the field. Please subscribe to the Rational Wellness Podcast on iTunes and YouTube, and sign up for my free ebook on my website by going to drweitz.com. Let's get started on your road to better health. Hello, Rational Wellness Podcasters. Thank you so much for joining me again today. For those of you who enjoy listening to our podcast, I would really appreciate it if you could go to Apple Podcasts or your favorite podcast app and give us a review and a rating so more people can find out about it. Also, if you want to see the video version, go to my YouTube page. And if you go to my website, drweitz.com, you can find a complete transcript and detailed show notes. So our topic for today is the use of bioidentical hormones during perimenopause and menopause with Dr. Cynthia Watson. Menopause is when a woman's body is shutting off its reproductive capabilities. A woman is technically in menopause when she has not had a period for 1 year. During perimenopause, the period prior to menopause, and menopause, there is a gradual but dramatic decrease in estrogen and progesterone production by the ovaries, resulting in a host of symptoms, including hot flashes, night sweats, brain fog, mood swings, sleep problems, depression, weight gain, vaginal dryness, hair loss, and fatigue, among others. Long-term effects of menopause include increased risk of osteoporosis and of cardiovascular disease. Dr. Cynthia Watson is board certified in family medicine, and she embraces a functional medicine approach to care, incorporating nutritional and herbal medicine and bioidentical hormones into her approach to health and wellness. After 2 years at Ohio State University, she lived on a biodynamic farm in Norway and developed an interest in the naturopathic medicine practiced on the farm. She also worked as a nurse's aide in a homeopathic hospital in Germany. She got her BS in chemistry from Duquesne University, and she went to the USC School of Medicine. She has had her own private practice since 1991, and she incorporates herbs, nutrition, homeopathy, intravenous vitamins, and bioidentical hormones into her integrative medical approach. She wrote a number of books, including Love Potions, A Guide to Aphrodisiacs and Sexual Pleasures, User's Guide to Easing Menopausal Symptoms Naturally, All About Alpha-Lipoic Acid, and Better Sex in Midlife. Dr. Watson, thank you so much for joining me today.
Well, thanks for inviting me, Ben.
So, what are hormones and why should we care about them?
What are hormones? Well, hormones is a broad definition because you're talking about like steroid hormones and other hormones. Hormones basically are defined as something that's secreted from an organ and that has an effect on an organ, on another organ. So, but there are the sex hormones are the ones that we deal with like in menopause and menstruation, and for both, and also for men too, they have hormones too.
Absolutely. So what happens during the perimenopause and how can we help women with their symptoms during this period?
So in perimenopause, there are a number of changes that can happen, and it varies from woman to woman. It also varies according to age, because some women will go into what we call perimenopause in their late 30s, early 40s, and some women will not even hit that period until like the mid 40s. Menopause, the timing for menopause is generally between 45 and 55. But prior to that, you'll see a number of changes. The most common changes are in terms of visual changes are problems with like irregular periods, where the cycles will either get shorter or the cycles will get longer. And sometimes they'll get heavier depending on what what kind of physiologic changes there are. I mean, the most common things are that the progesterone levels fall and the testosterone levels fall in perimenopause. And often the estrogen levels go up because as women, we're producing an egg every month. And as that gets weaker, the FSH gets higher, so the body's producing more estrogen, but the progesterone levels and the testosterone levels tend to fall. And what that translates into is you'll see women with either the cycles are getting shorter, where they're having like cycles every 3 weeks, it's even every 2 weeks sometimes if they don't produce an egg, or they'll have like 35, 40-day cycles. And what the other thing that goes along with that is a lot of irregular mood symptoms. I'll see irritability, more PMS, more depression, and also lower sex drive too, because the testosterone levels tend to fall.
So how can we support women during this phase?
So one of the most important things that I talk to my patients about is the adrenal gland. And I wanted to really talk a lot about that in this interview because as women, our adrenal glands produce hormones. They produce hormones just like the ovary does. And as we go into menopause, the hormone production, prior to menopause, the ovary produces about 75% of the hormones, the adrenal gland about 25%. And that shifts as we go into menopause, whereas the ovaries produce less hormone and the adrenal gland takes over. So what I see a lot in women in our, in our society, especially, is we're so busy, we're working, we're taking care of kids, we're doing so many things that the adrenal glands get weaker. And so the hormones, we see the hormone production cut down. And especially where that happens is with progesterone, because progesterone is used by the adrenal gland to make cortisone. So what happens is something we call it the progesterone steal phenomenon, where the ovary is making estrogen, it's making some progesterone, but the adrenal glands want that progesterone too. So as soon as that progesterone gets produced, it gets used up by the adrenal gland to make cortisone. So for me, checking a woman's hormones, most gynecologists check we learn to check the FSH and the estradiol on day 2 or 3 to see how the FSH is follicle stimulating hormone, and that's the hormone that is stimulated when we produce an egg. And as that goes higher, then we see less fertility and we see someone moving more into perimenopause. But the other important thing to check during that time is what we call luteal phase hormones, where you want to check the estrogen and progesterone and the testosterone around day 20 to 24, depending on how long the cycle is, to see how much progesterone they're making. And then depending on that, because I'll see women with low progesterone, I'll see women with super high estrogen levels, like 200, 400, I've even seen up to 700. And those women they're uncomfortable, they're miserable. It's like their breasts are tender, they're bloated, they're irritable. It's all of those symptoms go along with perimenopause. So
Go ahead.
So what you have to do about that is you have to help to lower the estrogen levels with herbs and supplements, which work really well to do that. And then if the woman needs progesterone, to give them progesterone during that time in the cycle.
What herbs and supplements can help lower the estrogen levels?
So this is an important thing, because I see women in their 40s where the estrogen levels start to climb as a combination of just this hormonal cycle, and also because of the environment. Because there's a lot of the phytoestrogens, and a lot of women are eating soy, or we're being exposed to some of these chemicals that the xenoestrogens, which then block our ability to clear estrogen.
Like bisphenol A, like pesticides,
right,
like
yes,
phthalates in personal care products.
Exactly. So just being cautious and being aware of those things that actually, clog up those cycles and make it difficult for us to metabolize the estrogens. And then there's also genetic factors, which I'm looking at a lot of the genetic factors, like certain CYP enzymes that they could have a polymorphism on, or the COMT enzyme, if you have a polymorphism on those, then you also have reduced ability to clear the estrogen. So what can you do? You can take a supplement called DIM, diiodomethane, which is the broccoli, the extract from cruciferous vegetables. That actually helps convert some of the estrogens into a weaker estrone. You can also take calcium D-glucarate, which in milk thistle. Calcium D-glucarate helps with the glucuronidation of the cycle and helps pull those estrogen levels out. And it really makes a difference for some women when they're retaining high levels of estrogen.
Do you ever use indole 3-carbinol versus DIM?
I tend to use more DIM.
Okay.
Yeah.
And why is that?
Well, just from some of the research that I saw, the DIM is the downward metabolite of the indole 3-carbinol, so the DIM is actually a little more effective.
Okay, great. So you were talking about the hormone levels, the estrogen going up and the progesterone going down. What's the best way to test or measure hormone levels? And we have serum, we have 24-hour urine, we have dried urine, we have saliva.
Yeah, there's a lot of different testing methods. I think I'm more partial to blood. That's kind of what I've been doing for all these years. So I found, and I think it also depends on the practitioner and where their level of comfort is, because I'm used to looking at blood. I know how to interpret the blood. I'm comfortable with it. If that's something that you're comfortable with, that I think blood levels are fine. Urine levels are helpful for the urine metabolites of the estrogen. So if you've got someone who you think is not metabolizing the estrogen, you can get a lot of the estrogen, the estrone metabolites. You can get the 2,16-hydroxyestrone and the 4-methoxy and 4-hydroxyestrone. So you can see if someone's got high estrogen, where you need to help them in that cycle to clear the estrogen. And then so that's really only with urine. So if I have someone where I really need that, I'll do urine. I think progesterone levels are not very good at urine because you're not really measuring the actual level, you're measuring a metabolite. So I tend to use blood, and I tend to check the blood depending on where the woman's cycle is. I tend to check the blood between day like 20 to 24, but if I have someone with a 21-day cycle, I'm going to do day like 18, something like that.
Yeah, we've started using the dried urine more, and one of the things that's beneficial for that is you're talking about trying to get a woman on day 18 to 21, and a lot of times, oh shoot, that's a weekend, I can't go, I'll have to wait till next month. So
Yeah.
this way they can do it at home and send it in.
Yeah, I mean, I'll just adjust it based on whatever, day they can do it. But yes, I sometimes do the urine as well.
Right. What else can we do as far as the progesterone? What do you think about using herbs to support progesterone production during the perimenopause?
I love the Vitex.
Right.
Vitex is the best herb for women in those perimenopausal symptoms. Even for some
AKA chasteberry.
chasteberry. Yeah,
Yep.
chasteberry is a great herb for that. I found a lot of my patients, when you give them progesterone, they get side effects. So sometimes I'll just go to the chasteberry first, see how that works.
What dosage do you like for the chasteberry?
I usually use about 200 milligrams twice a day.
Okay.
Yeah.
Good.
And I don't cycle it. I usually have them do it continuously.
Okay. Good. So what happens during menopause, and why is it that some women sail through menopause with, fairly manageable symptoms, and the symptoms are severe and unlivable?
Yeah, I mean, I don't know if we really know why some women have different symptoms. Because I've seen some women, you would think that some women who are like a little more overweight, that they have more endogenous estrogen, that they wouldn't have as many symptoms, but sometimes they do. So I think some of it's genetic, because I think some women, if their mother had an easy menopause, that they may have an easy menopause. And again, I go back to like the stress issue. Some patients, if they've had a lot of stress and the adrenal glands aren't able to carry them, they're going to have less estrogen. I've seen some women have like very low estrogen levels and then they're fine. So I don't know if we know why, but certainly there are some women that have really disabling symptoms. And those are the women that I think are good candidates for the hormone replacement.
Okay. Now, isn't it the case that the Women's Health Initiative, which was published in 2002, showed that taking estrogen and progesterone increases the risk of heart disease and stroke and blood clots and breast cancer?
Well, that study, as as you know, is and as reported by many many doctors, and even some of the doctors that even were part of the study, um, that the results on that study were very confusing. I mean, I think first of all, the product that was used on that study, let me start with that, is Premarin and Pravera. Pravera is a synthetic progesterone. So physiologically, the effects of synthetic progesterone on the body are different. And Premarin, which is the pregnant mare's urine, is mostly estrone. So because of that, it's a different kind of estrogen, and it's metabolized in the body differently. And to add to that, it is also an oral estrogen. So we tend to try to use more topical estrogens in some women, in women postmenopausal. Uh, the other problem with the study is that most of those women in the study were actually not having menopausal symptoms. And the reason for that is because they were doing placebo controlled. So they were looking for women who didn't have menopausal symptoms. So because if they did, they would know they would know whether or not they were on a placebo or not. So that's the first thing. The other problem with the study was it was a prospective study. And a prospective study means that if there is a complication, they need to stop the study. So it wasn't just an observational study, it was a prospective study. And what
Now,
happened,
aren't prospective studies the most accurate?
well, yes, but the way it was interpreted, because there was a slightly higher statistical evidence of cancer, they had to stop the study. But the statistical evidence in that study was a very small group of women that there was, first of all, on the estrogen, there was an arm of the study that was estrogen alone. They're just Premarin alone. These are women that had had a hysterectomy. In that study, there was no increased risk of breast cancer. In the part of the study that had the estrogen with progesterone, those patients, there were out of 10,000 women, there were 32 cases of breast cancer. In the control group, there were 24 cases. So there were only 8 cases more um, in the treated group. But because 8 goes into 32 3 times, it was recorded as a third more cases. And so even though that was a very small statistical study, prior to that time, many of the studies, first of all, there's a wonderful book if patients want to read a little bit more about this that I don't know if you're familiar with this book. It's called Estrogen Matters, and it's by Avram Blooming. And he's a wonderful gynecologist who, oncologist who it was in San Fernando Valley. He was one of my referrals, and he was one of the only doctors after breast cancer that would treat women with hormones, and became quite controversial. He was really in the firing line for a long time because of this. And then one day I was referring in patients, and one day I found that he retired, and then a few months later I saw this book, so saying Estrogen Matters, why we why we can give women estrogen even after breast cancer. So he's the one that did a lot of the research, and he produced a lot of studies. Up until that time, there were very few studies that showed that there was an increased risk of cancer. And then in the studies in Europe, the studies that use bioidenticals, because they tend to use more bioidenticals, they use more pure estradiol, and they use a lot of natural progesterone. There's a very large French study that did not show an increase in cancer. So let me address the heart disease and the stroke. So part of the problem too with that study is that many of the women in that study were obese, many of them smoked. And what they're finding now is the risk of cancer and heart disease and stroke really has to do more with obesity. And that's been one of the main things. There was a very large article that was written by NAMS, the National Menopause Society, and the International Menopause Society, showing that the risk of breast cancer and stroke in these women is really it's really from the obesity that seems to be the problem.
I've really been enjoying this discussion, but now I'd like to pause to tell you about the sponsor for this episode of the Rational Wellness Podcast. This episode is sponsored by Pure Encapsulations, which is one of the few lines of professional nutritional supplements that I use in my office. Pure Encapsulations manufactures a complete line of hypoallergenic, research-based dietary supplements. Pure products are meticulously formulated using pure, scientifically tested and validated ingredients. They are free from magnesium stearate, gluten, GMOs, hydrogenated fats, artificial colors, sweeteners, and preservatives. Among other things, one of the great things about Pure Encapsulations is not just the quality products, but the fact that they often provide a range of different dosages and sizes, which makes it easy to find the right product for the right patient, especially since we do a lot of testing and we figure out exactly what the patients need. So, for example, with DHEA, they offer 5, 10, and 25 milligram dosages in both 60 and 180 capsules per bottle size, which is extremely convenient. And now, back to our discussion. What type of estrogen and progesterone do you like to use in menopausal women?
I use all bioidenticals and primarily estradiol. I know some doctors use the bias combination, and I do
Right.
use that in some of my patients, but I tend to use more of just pure estradiol.
And why is that?
Um, I found that some women don't tolerate the estradiol as much, the estriol as much, and since the estradiol it has the strongest effect on menopausal symptoms. What was happening is you're giving estriol and estradiol, because estriol is a weaker estrogen. You were having to give higher doses of it. So there are some women, especially some women, they just don't do as well on it. Some women do. So I think again, when I'm working with a patient, everything's individualized. I mean, what I would give them would be on an individual basis based on their body weight, their family history, whether or not it looks like they've had a problem clearing estrogen in the past. Because I think that's one of the other things that I try to really pay attention to is just if I have someone who has a history of like fibroids, ovarian cysts, like PMS symptoms, if they've had problems, if it looks like they've had, or they have problems metabolizing the estrogen, I'm going to want to use lower levels.
I think a lot of the women who are, a lot of the doctors who are using Biast or using estriol are using it to potentially lower the potential risk of breast cancer, since estriol is a weaker estrogen.
Right. I mean, I have actually a couple of women who have had breast cancer and they're on estriol. Estriol is really great for the vagina. I mean, for vaginal dryness, estriol is a
Right.
wonderful product for that, just
Right.
for topical application.
Right. I know I interviewed Dr. Gersh, and she's not really big on estriol because she explains that estriol is a dominant hormone secreted during pregnancy, and it basically stimulates the estrogen beta receptors. And so you miss stimulating those estrogen alpha receptors that are so important, and overstimulating the beta receptor actually downregulates the immune system, which is maybe good for pregnancy, but not so good for fighting off infections or cancer.
Yeah, but when you're using estriol and hormone replacement, you're using such small doses compared to what the body's secreting in pregnancy. I mean, in pregnancy,
Okay.
you've got super physiologic, really super high
Okay.
levels. Um,
And do what form of the estrogen and progesterone? You like topical estrogen? Have you used pellets?
I mean, I use whatever is going to work on the patient. So um, I have generally try to start with some of the topical forms, because the topical forms are you don't have to deal with that first pass effect. So you're using oral estrogen long term can increase clotting factors. So you can have some concern with the liver, and if
By
you've got some
first pass, what you're saying is when you take an estrogen orally, it goes into the
highest levels go into the liver.
right.
Yeah.
Exactly.
But I
Okay.
do use sublingual forms as well for
Okay.
some of my patients. If they're not getting, some women just do not absorb the creams, or they're not going to do it. I mean, they're just not going to do it. So if it's better in terms of using the, if they're going to get, if you're going to get better compliance and they're going to be happier using one of the other forms, I'll use whatever is going to work.
Now, one of the issues with using the creams is that serum testing may not accurately reflect uh, hormone levels if they're using the creams. Is that right?
Do sometimes I some well, I see both. I mean, I see some women where I'm just not getting good serum levels. That's true. Um, and I know that salivary levels can be used for that. My problem with salivary levels is that I'm just not sure how they know standardization, how they know like what is an actual good dosage. But I see women on the creams all the time and on patches all the time that get great blood levels. So I think that's not as much of a problem. With the progesterone though, sometimes I have trouble getting good blood levels. And I have a lot of women that sometimes I have to switch them to oral progesterone. I mean, the oral progesterone doesn't have the same risks as the estrogen. It's very well absorbed. It actually helps better with sleep. So a lot of my patients will do the oral progesterone instead.
Now, when a woman's menstruating, her progesterone levels are much higher during, a couple of weeks during the period, and estrogen levels tend to fluctuate and spike prior to ovulation. Um, do you use static dosing for hormones, or do you use rhythmic dosing?
I tend to use more static dosing for hormones, although there are certain doctors that will do the rhythmic hormones, and I'm learning a little bit more about that. And I have a couple of patients who have been doing that. There's the Wiley protocol, which was kind of the first protocol for that. Um, I think it just depends on the patient and what they're going to be able to do. Um, if you have someone who's not going to be able to pay attention to like switching off and doing a different dose every single day, then you're not going to get good compliance. I sometimes have trouble with women even remembering to take the progesterone. um, and I'll say, like, you got to take that progesterone. It's really important
Right.
if you have a uterus.
Right.
And there are some women that actually don't have a uterus that like the progesterone anyway.
Right.
They actually feel better on it.
So the reason why the progesterone is so important for a woman who has a uterus is because it stimulates the sloughing off of the increased endometrial tissue that happens from the estrogen, right?
Well, it's not so much sloughing off. It just balances the possibility of the estrogen causing the lining to get thick.
Right.
Because in women that are doing these static dosing, we don't usually see them bleed. So
Okay.
it's not like the lining is getting thick.
Right.
If they've got an adequate amount of estrogen and progesterone, it's usually, and it's also, these are low levels. We're not doing high levels like someone does, when they're menstruating. So you won't necessarily see the lining get thick if you've got the dosage right.
Right. Do you ever measure the uterine lining level?
All the time. All the
Okay.
time. Yeah.
So, does hormone replacement therapy protect the heart?
Well, that's a controversial question right now. What according to the research, if you start estrogen early on, if you start it early on in menopause in the first few years, I mean, that's one of the things that we're encouraging right now, is that the benefits that women get in menopause starting hormone replacement early, um, it's better to start early in terms of protecting the bones, protecting the heart, protecting the brain. Um, what happened was
So
when
when
they
you
took
say
when they
so when you say starting early, you mean during perimenopause or shortly after menopause starts?
within the first year of menopause,
Okay.
really. Um, I tailor my hormone replacement to women based on what they're comfortable with. There are a lot of women that are, if they're afraid they're going to get breast cancer and they're doing fine, then I'm not going to push hormone replacement on them. That years ago, when I first started practicing, and then there were a lot of women who were trying to decide whether to do hormone replacement. Because there was the research indicated that it had such good protection on the heart. I had patients come to me and say, my gynecologist wants me to take these hormones and I don't want to do it. Because the gynecologists were really like, this is going to protect you and this is really important. And then the study came out, and everyone like, go off the hormones. These are bad. They're dangerous. Stop the hormones. So now we're kind of in a like reset period, I think, where you have to really choose what is going to be best for your patient on an individual basis.
What do you think the consensus is right now in the standard gynecological community?
Unfortunately, I think there are a lot of gynecologists out there that still are not for hormone. They're against hormone replacement.
Right.
Because
they tell the patients that they're unsafe, right?
Yeah, exactly. Which I don't believe to be true. Although, again, I think it depends on each individual person, and based on their family history.
Yeah, from what I've
and
seen,
also their
from the
symptoms. Like
conventional.
if I have someone who comes in and they're having like no symptoms whatsoever, they're sleeping fine, they're doing fine, they're not having any menopausal symptoms. I may just give them a vaginal cream, because the vagina usually will need some, estrogen support. But I'm not pushing hormones on someone just because. I think I try to, right now the national menopause NAMS, the National Menopause Association, I mean, they recommend using hormone replacement for menopausal symptoms, for quality of life symptoms. And so if I have someone who's really having bad symptoms, I will encourage them to use some hormone replacement.
What about women who have a history of breast cancer but are having vaginal symptoms? I've heard some practitioners using topical testosterone and even topical DHEA for women who
Right.
are really petrified about taking estrogen.
Yeah. So I mean, there's two classes of women, things here. There's the woman who had breast cancer. Now, I actually have some of my patients who've had breast cancer on hormone replacement, because their cancer was like a slow growing cancer. It was it was easily excised. It was small. It was low risk, and their symptoms are so bad in terms of like depression, mood swings, hot flashes, sleep problems, that I will put them on a dose of hormones. But then if I have a woman who's postmenopausal, I mean, she's had breast cancer and she's not having any symptoms, or that she's being followed by an oncologist who has, specific, like, don't give her hormones. You can use estrogen, just estradiol cream. You can use estriol cream. You can use DHEA. DHEA, there's a commercial grade suppository, and then there's an over-the-counter grade suppository with DHEA. Testosterone works great in these women and sometimes even helps with some of the menopausal symptoms. So all of those things are viable options for a woman that doesn't want to do systemic hormones for just the vaginal dryness.
So which is your go-to? Is your first thought to use a topical estrogen rather than the testosterone or the DHEA, or do you think they all work equally effectively?
For a woman that's had breast cancer?
For a woman who's had breast cancer, but who wants help with the vaginal, dryness and atrophy.
I mean, I'll usually use the estradiol first just to see how they do. I mean, I check blood levels. So if someone has a low testosterone, I will, testosterone is very well measured in the blood. And if someone's testosterone is low, or the estrogen doesn't work, or they're having like sexual dysfunction where they're having trouble with orgasm, testosterone works really well for that. It also works really well as an antidepressant. I've had some women, even, not with breast cancer, but some women, I had one woman, I gave her testosterone and she went off her antidepressant because she didn't need it anymore. So there's a lot of good benefits to the testosterone, but there's side effects too. I mean, you can get hair loss, you can get acne, and you can get irritability. There's some women, even with the lowest dose of testosterone, they'll get, rage and irritability and sharp with their partner, and we don't need that. So, some women just have bad effects from testosterone, but for the woman that testosterone works for, it's amazing.
So for your typical protocol, when you have a woman getting away from the breast cancer thing, you just have a woman in first year of menopause and you're going to put her on a program. Besides putting on estrogen and progesterone, do you typically, if testosterone levels are low, if DHEA levels are low, do you typically supplement those as well? And what about other hormones like pregnenolone?
Um, I tend to, my experience with pregnenolone, even though I love it, and I think it can be important for like brain health and function, especially if you have someone who's got like MS or, even any kind of neurologic problem. But I've never seen, I mean, theoretically, it's supposed to have a cascade effect where you take the pregnenolone and it goes into different pathways. I've not really seen it actually raise estrogen levels. Um, so I will use it if the levels are low and if someone's having those particular symptoms. What I like to do is usually start them on estrogen, and we discuss, which kind to use. Like the patch, I mean, there's the other issues that, the controversy about like compounded versus commercial brands, because they're, um, they're, in the conventional medical, you know, wisdom, like the OBGYNs group, the American ACOG, the American College of OBGYN, they're totally against compounding. They talk about compounding as being like, it's not measured, it's not accurate. You have no way of being of quality control. And
And there's been a movement to try to shut down the compounding pharmacies, right?
right. And I try to use compounding pharmacies that I know that have reliability, that I know do batch testing. So they test their products. So I know that I've got someone who's really paying attention. I mean, have I seen some women get a batch and say, this is not right, or it's something wrong with it, or there's some their levels are really high? Yes, I have seen that before. I mean, don't forget, there's also, even in like the generic versus brand, there's a certain percentage, like what, 20%, which doesn't have, it's not, it has either low levels or higher levels. So,
Oh, we
you know,
were actually,
right.
it's a whole nother topic we can
Yeah,
get into, but
right.
there's a
Yeah,
huge problem with generic drugs
generic
right
drugs renowned. Yeah, I'm seeing a lot of that with a lot of the drugs that I see. Um, but so I'll use the patch. So again, it depends on the woman. It's like if they don't want to wear a patch because they're swimmers, or they take baths or exercise a lot, I'm not going to use the patch. But if someone who wants to be able to get the 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 hormones covered by their insurance, the patch works great. And if they're not going to put a cream on every day, the patch works great. And it is bioidentical estrogen. It's the pure estradiol. And then
And
there are a couple of other.
what are the advantages of using compounded hormones?
Well, I like them because you can titrate the dose more easily. And you can also decide, um, you can start with lower doses and titrate up. If you have someone who, you're not sure what their dosage is going to be, it's a little bit easier to do that. And also, if you've got someone who you think is going to have trouble metabolizing the estrogen, I mean, I'll give them estrogen and it's like, whoa, it's way too strong. Even the lowest amount, you can have them stop for a couple of days. Once you put the patch on, you have a little bit less regularity. The other thing, some of the other commercial brands of estrogen that are available at the pharmacy, they're in an alcohol base, and I tend not to like those alcohol bases very much, but some women do fine with them.
And sometimes women can have reactions to the binders and fillers and things like that they're made
Right.
with. So by going to a compounding pharmacy, you can have some control over how they're made.
You can have it. Some of my patients have the estrogen put in olive oil, which is very clean. They can just put it right on their skin. There's a company that'll make it in emu oil. So, I mean, and you can use like hypoallergenic bases. So yeah, for especially someone who's sensitive and going to be sensitive to chemicals, there's a lot more options with compounded. And also, I found that the compounded progesterone, the regular progesterone, the commercial grade progesterone, is in peanut oil. And some women can't do the peanut oil. So you can have the progesterone made compounding pharmacy with in like an olive oil base or a canola oil base, or even a powder base.
And then how often do you add DHEA and testosterone as part of the mix?
Well, I usually start a woman on the hormones and then recheck I like to use estrogen and progesterone alone to start, because then if they have a side effect or if there's anything that changes in terms of like their metabolism, um, then I know exactly, what to do, and I'm not dealing with like a lot of other variables, because with the like testosterone and DHEA, those hormones also can go into the metabolic pathways. And if a woman has a very strong aromatase level in her body, she'll convert that DHEA and the testosterone into estrogen. And I've seen that happen before. So I don't want to add that in until I know what I'm dealing with how they're doing with the estrogen. So I will start on estrogen and progesterone. After about a month, I will check the levels and see where they are, and then add in the DHEA and testosterone if their levels are low.
Okay. Um, so what about the benefits of bioidentical hormones for the brain?
Well, there's a lot of research that shows that the hormones really are beneficial for the brain. I mean, there's certainly, even in the women's health study, so there's some confusing things in that study, because on the one hand, it did show that there's less Alzheimer's in women on hormones, but then the there was at one point a study that came out that showed that there was increased dementia. And again, I bring up the issue is, like, in that study, those women were, so here's the other benefit of starting the hormones a little bit earlier. Um, if you start a woman on hormones later, you don't get the benefits to the vascular system, and you can get more um, plaque formation, more atherosclerosis. One of the few things that no one talks very much about is that the estrogen and progesterone have a protective effect on lipids. I mean, I see this all the time. I have a woman who's got I'm one of them because I always had a cholesterol of like 180 something. Like, my cholesterol was like a non-issue. And as soon as I went into menopause, even on hormone replacement, my cholesterol's like a little higher. My LDL tends to be a little bit higher. So that's, so what happens in that study where they took all these women, they started a lot of these women in their 60s, and they're who could have had already vascular changes already. Um, and then you add to that the fact that you're using an oral preparation, which increases clotting factors, so you're going to increase the risk of stroke. So if you look at um, all those statistics, it's you can't actually you can't make assumptions that if you start a woman in their early 50s on the bioidentical hormones, that it's going to increase their risk of stroke, because it's like comparing apples and oranges. Um, but it's very, very clear that women, there's better cognitive function um, in women on hormone replacement.
Oh, I just wanted to cycle back to one thing you talked about before.
Or
You were talking about the adrenals. How do you
right.
assess adrenal function, and how do you support adrenals?
Well, first of all, you want to test. Like, I'll do a test. And part of my hormone panel is to check the cortisol levels. So I'll look at cortisol levels,
You're
um,
talking about serum cortisol.
serum cortisol levels. But in some of my patients, I will also do the salivary levels, the 20, what's basically a 12-hour salivary test, where you do morning, noon, afternoon, evening.
Do you
Because,
include the cortisol awakening response?
right, yeah.
Okay.
You'll see some women who will, like, they'll spike in the middle of the night, or you'll see where they don't really get a good um, cortisol. The cortisol should be higher in the morning and then go down as the afternoon goes up. You'll see some women that are flatline, and then they go up at night. And these are the women that are having trouble sleeping. You can also, and then there's also the dried spot urine. There's a company that does the dried spot urine, where you're doing like the 4 samples throughout the day.
Right, the Dutch testing.
Yeah, the Dutch
Yeah.
testing. Yeah.
Yeah, actually, one of the advantages of that is when you do the cortisol awakening response,
Hmm.
um, and they have to spit into a tube as soon as they wake up. That's always problematic. But
Right.
the
Yeah.
Dutch testing, they just put a little cotton swab in their mouth, get it wet, and that's all they have to do.
Yeah. Yeah. No, it's a good test. It's a good test. So for adrenals, I tend to use more herbs for
Okay.
the adrenal gland. There's a lot of great formulas that are out there. One of the other herbs that really is good is maca root for women, for both perimenopause and into like early menopause. And even some of my women who have had breast cancer and who don't want to use hormone replacement, maca is a great is a great herb because it doesn't actually have plant estrogens in it. It basically helps stimulate the production of estrogen and testosterone. Um, so maca is a great herb. Licorice root, just the ginsengs, um,
So now, do you have different protocols if they're seeing like a spike in the cortisol in the evening as opposed to when it's just sort of flatlined the whole time?
Oh, for sure. Because you'll for the women that have the spikes, I'm using the phosphoserine products. There's a couple of products that have phosphoserine. Magnolia works great. There are a number of commercial products that are just, help to lower that cortisol level, and so you give it to them in the evening, and that really helps. Um, yes, I'll use a lot of those. Ashwagandha is another one. That's another really good herb for women that are having that, or even men that are having that issue where they're like having trouble sleeping and we think the cortisol spiking.
Right. And then the maca and the licorice root and some of those things to help stimulate the adrenals.
Right. Again, it depends on the person. If like you've got someone who's spiking cortisol, you don't want to do like heavy duty adrenal stimulants. You want something like you want a good adaptogens. And that's where the ashwagandha and the maca root really help with that.
Okay. Good, good, good. I think that those are the questions that I had. Is there anything else that you want to say before we wrap up our discussion here?
I
And
know
if,
you asked me about the pellets, and I didn't really
yeah,
address that
okay.
question. So
Yeah.
I know some women really benefit from the pellets, and they like it because it gives them like they don't have to really worry about like putting something on like a cream or a patch or taking a
Yeah, I
pill.
know some women are kind of concerned about the cream. It's a pain. Maybe if
Right.
they don't want to get it on their partner, and there's a bunch of different concerns that women have about the creams.
So I think it's a very individual decision. I think the issue that I have with the pellets is that I see really high levels sometimes in women, and they get side effects from it where they get like breast tenderness, and because the levels are very, very high because they
And
put the,
you can't adjust it once
you
you put them
can't
in.
adjust it. Yeah. So I tend to not use the pellets in my practice. But again, I've had women who just love them. I had a couple of patients who just it was great and they were very happy. So I think it's again we're very fortunate in that we have options. We have a lot of choices for women. We can individualize therapy, and I think of everything, I think that's the most important thing is that there is no cookie cutter approach. There's no, because years ago there was like take Premarin and Provera, that was the thing, there was one dose and that was it. It is not a one size fits all. You really have to individualize it based on each individual patient, their genetics, their particular, where they are in life, how they metabolize the hormones. Everything's got to be individualized.
What is the status, by the way, of compounding pharmacies? I know that there was a movement to pressure the federal government into shutting down compounding pharmacies, and I know there's a lot of controversy about it. Where are we in terms of that situation, the political situation?
I, I'm afraid I'm not really up on the latest of that, except I don't. The compounding pharmacies they're still providing
Right,
hormones for my patients, so
right. I know,
I haven't
I
heard anything
remember signing
back.
some
Yeah,
petitions to try to
yeah,
keep them from closing them
yeah.
down.
I don't think they're going to be able to close them down. I think there's too many patients that are getting benefit out of it.
Yeah.
So
By the way, do you have a preferred dietary approach for menopausal women?
Well, as we go into menopause, we definitely have metabolism changes. I see that. So I'm usually more into the like paleo diet, into more like, making sure you're getting, it doesn't have to be high protein, but you need to make sure you get adequate amounts of protein. I mean, I love a plant-based diet and I think it's really great, but it's just not for everyone. And so some of my patients that are doing a plant-based diet, but it's too high in carbohydrate, not enough protein. And even if they're on a plant-based diet, as long as they're getting good amounts of protein, they're fine.
How do
But
you
generally,
include
the diet
how,
that I've been able to maintain my weight into menopause, and how I do that is I eat a lot of vegetables and salads and lean protein and just keep the carbs and sugars to a minimum.
What about the women who are on the plant-based diets? How can they get an adequate amount of protein? How much protein is adequate, and how can they get that without consuming a lot of phytoestrogens?
I mean, there's the uh, the recommended dose that I use is about 40 to 60 grams of protein a day, depending upon how, what their needs are in terms of how much they're exercising.
Their
Because
body weight, how much exercise? Yeah.
yeah, because as you know, if women are exercising a lot, they need more protein. So using protein supplements with, like pea protein or rice protein powders, um, just uh, working with them on trying to avoid too much soy. So to use other plant-based
Now,
protein
what about that
sources.
whole soy controversy? Because soy contains phytoestrogens, and some of the data seems to show that soy is protective against breast cancer because when you
Right,
consume,
it's weaker estrogen.
you get the
Yeah.
weaker estrogens that glom onto the estrogen receptor sites and block the stronger estrogens. And the largest study, I think, of menopausal women who consume the most amount of soy, these were Chinese women in China who had a history of breast cancer, had the lowest risk of recurrence.
I mean, I think there's a like premenopausal issue with soy and a postmenopausal issue with soy. Because certainly in the premenopausal period, when you have women with high hormone levels taking soy, then that's a problem because it's too much. And I've actually seen some women like get breast problems and heavy bleeding and fibroids eating a high soy diet. The other problem with soy is its effect on the thyroid. Soy has an anti-thyroid effect. So I'll see some women, if they're eating, like drinking a lot of soy milk or eating like a lot of soy-based products, their thyroid goes off, like their TSH will go up, but their thyroid's still functioning, but the TSH is up, and then you get them off soy and their thyroid normalizes. So um, I'm not a big fan of soy because of that. Plus, it's very difficult to digest and can cause a lot of like GI bloating, gas issues. So but again, postmenopausally, where you've got women who've got low estrogen levels, then those women may benefit from soy, as long as it's in moderation. In places like China and Asia, they're eating small amounts of soy. They're not consuming large amounts of tofu and drinking soy milk. Um, it's a different, if it's a different kind of intake. It's a smaller. They're not taking a large amounts of processed soy. They're maybe eating tofu or something like that.
So, how else can these women get enough protein besides soy? You say plant-based protein powders with pea and rice. Those are the
Yeah.
kind you like the most.
Yeah.
What
If
else?
I see that they're not, I mean, I have some women, I have a couple of women that are very, very, they're working out quite a lot. And, what I see in women that are doing a high plant-based diet is you have to watch their iron levels, and you got to watch their B12 levels, because they make sure they're getting adequate amounts. And yes, various different protein forms. I mean, there are these different um, processed protein, different, there's like the whole thing, right? The Impossible Burger and Beyond Meat and all that stuff, which,
What,
I
what's
mean,
your
it's
take
a
on
very,
that?
well, it's a very highly processed product. But again, it depends on if they're not getting protein any other way, then that may be something that they might need to do. But I just try to get them to do like combinations of like lentils and beans and rice and things, but just keep the portions small enough so they're not getting a high carb load. But it's possible to do. I mean, we have people that are working out that are
Right.
gaining muscle mass, and I'm sure you have them too,
Yeah.
that are eating a plant-based diet. It's definitely possible. You just have to be conscious about it. And what I tell people to watch for is watch for their sugar cravings, because if you're craving sugar, you're not getting enough protein.
Or you
So,
taking in too many carbs. Yeah.
right. Yeah.
Yeah. So your preferred diet is a paleo diet that's basically lower in carbs, and it basically does not include grains and beans like the paleo diet does.
I mean, again, it depends on the person and how they
Right.
metabolize that. But if for me, because I'm postmenopausal and I'm on hormone replacement and I've been able to maintain my weight all of these years, that's what's worked for me. Um, and that's what has worked for me. So I'm still the same weight I was when I was in my 20s.
Great. Awesome.
So I really don't need a lot of sugar. I mean, I think that's the key.
Yeah,
I keep that to a minimum in terms of
yeah,
like sweets and candies and things, not part of my diet.
that's good. Okay, awesome. So how can listeners and viewers get a hold of you if they want to contact you or find out about your books?
Well, I have a website, but the books actually, unfortunately, were out of print, and
Oh,
I've been
oh,
very
out of print.
busy in my
Okay.
clinic, so I
When's your
haven't
next
really.
book coming out?
Yeah, that's the question. Well, I have to be. I'm a full-time clinical practitioner, so not a lot of time to write books these days. Maybe if I slow down a little bit, I'll have more time to do that. But it's
Okay.
just not part of my schedule right now. I'm pretty busy in the office. I've got a big practice. I've been practicing for a long time. I have people I've taken care of for a long time, so that's the main focus for me. My website is watsonwellness.org. So you can that people can check that out. There's a lot of information on the website about me, and yes, the books definitely are something that I would like to get back out again, but just doesn't seem to be part of the schedule.
Well, you could take one of those books and just come up with a new version of it.
Right. Yes, that's on my to-do list.
And are you accepting new patients?
Yes, I am.
Okay,
Yes.
awesome.
Okay.
Thank you, Cynthia.
All right. Thanks, Ben. You have a great day.